Let's go to the next question. Leprobacilli can survive outside the human body up to what time? So I could not get a very authentic answer for this, but at least the latest I could see is 9 days. So 9 is anyway not there. I'm not sure to commit on 7 or 12. So you can give me your possible opinion at the end of the class. Now let us go to the next question. Moclobemide typically is a MAVO inhibitor, as all of you know very well. It is a benzamide derivative. It inhibits not only the deamination of the norepinephrine and dopamine but also to the serotonin. And by inhibiting that, it will make their concentration to increase, and that accounts for the antidepressant action of the moclobemide is what need to be remembered. Now between MAVO A and MAVO B, which is selective? Moclobemide, selective for the MAVO A is what I want to underscore to all of you. Let's go to the next question. Loading dose typically depends on which factor? This is a little challenging question. You have to be really brainy because generally we ignore that pharmacokinetics part of the pharmacology as usually. So we should not do that. I'll take 2-3 minutes of your extra time to make you understand this fundamental question. Already you know very well. Volume of distribution. What is the meaning of this? Whenever we inject a certain amount of drug, typically the amount of the drug divided by the concentration in the blood will give you how it got distributed across the body. The drugs which are highly lipid soluble, for example the digoxin, they will be having a very high volume of the distribution is what I want to underscore. Whereas those which are lipid insoluble like the neuromuscular blockers, they remain within the blood without dissolving, hence they have got a low volume of distribution is what I want to underscore to all of you. One more term is there that is called clearance. The volume of the plasma from which the drug is completely removed per every unit time is called the clearance. So it is like sadness. How much of sadness we could clear every day will make us more happier. So clearance is every unit time how much of drug is removed from the plasma will give you clearance. And the amount which is eliminated is definitely proportional to the concentration of the drug. That is, clearance is dependent upon the concentration of the drug and vice versa is what I want to underscore to all of you. So if you take at any given point of time, the fraction of the drug which is eliminated by the body for every unit time is typically determined by a very important constant called the elimination constant is what I want to underscore to all of you. How do you calculate this elimination constant typically? Very simple. You administer a drug, look at its concentration as the time is progressing, you will get one curve, take the slope of that curve, that gives you the elimination constant. So there is a reason, doctor, clearance divided by the volume of distribution will give you the elimination constant and rate of elimination is equal to the clearance into concentration of the blood is what I want to underscore. One more important parameter is the half-life. 1-2 important points about it, let us be sure about. Typically the time which is taken for the plasma concentration to reduce by about 50% is called elimination half-life. If 4 elimination half-lives are passed, doctor, finally only 6% of the drug will be remaining, 94% will be cleared is what need to be basically remembered. So how do you get this half-life? It is the logarithm of the 2 into the volume of the distribution divided by the clearance. So 0.693 into volume of distribution by clearance will give you the half-life. So now if the volume of the distribution is increased, then what will happen? The elimination constant become decreased. The half-life will also decrease, it will increase, but the clearance will not change. Though you have changed the volume of distribution is what I want to underscore to all of you. Now if you take a typical graph after you have administered the drug, typically there is a rapid redistribution phase when the concentration will steeply falling down and then slowly it becomes eliminated is what need to be basically remembered. One more important term is there called the bioavailability, which we need to basically understand. Very simple. If you have administered a drug, finally where it has to reach systemic circulation. If there is more amount of first bypass effect, then obviously it can't be reaching that. So there's a reason, doctor, bioavailability is the fraction of the administered dose that reaches the systemic circulation is called the bioavailability is what I want to underscore. How do you calculate it? Very simple. You know that after you have administered drug, it is achieving certain concentration in the plasma and over a period of time slowly concentration is falling down. So the area under this curve of this concentration to that of the time will give you the bioavailability is another important problem that we have now solved. Now the question is, what is this loading dose and maintenance dose concept basically? Very simple. maintenance dose typically is equal to that particular, it is basically dependent on the rate of elimination at the point of the steady state. So that's the reason, doctor, one of the very important parameters on which the maintenance dose, how much you have to administer to the patient, will depend upon the clearance of the drug. Suppose if the individual is clearing more amount of drug, his concentrations are falling down, that's the reason you need to give more amount of the maintenance dose in order to maintain that particular concentration. Suppose if the clearance is lesser, then you need to give less amount of maintenance dose, even you need to interval it a little longer is what need to be remembered. That's the reason these concepts are all very important when you are managing the patient. For example, if I am having renal failure and you are administering imipenem or vancomycin to me, then when the kidney is damaged and the vancomycin clearance got decreased, then instead of giving vancomycin every day, you need to plan it to give second day, third day, fourth day, like that. So there's a reason, doctor, maintenance dose invariably depends upon the clearance. Now I like to ask, rather the examiner asked you a question, is the loading dose is also dependent upon the clearance? No, the loading dose is not dependent on the clearance is what need to be remembered. Typically the loading dose is dependent on two things: the volume of distribution and the desired concentration which you want to achieve. Suppose if the drug is highly lipid soluble, it is wonderfully distributed across the whole body tissues, you need to increase the amount of the drug value, that is you need to increase the loading dose. Suppose if it is not distributed, even less amount of dose you load itself, it will achieve that peak concentration. So you require less amount of loading dose. That's the reason, doctor, only on two important parameters loading dose depends on. Number one, the volume of distribution. Number two, on that actual peak concentration, which is effective concentration which you have decided. Whereas maintenance dose is dependent on the clearance is what I want to underscore to all of you. So this gives you a classical example, doctor. Phenytoin, all of you know, is a very important drug, and you expect that it achieves a concentration of about 10 to 20 milligrams per liter for it to be a very effective anti-epileptic. Suppose you want to achieve the concentration, effective concentration of 20 milligrams per liter, and if I give you that the volume of distribution of the phenytoin is about 0.7 liters per kg, and I ask you calculate the loading dose and administer to the patient as a neurologist, how are you going to do as an intern, doctor? It is 20 into 0.7, that is 14 milligrams per kg is what you will calculate, and the 50 kg individual means 700 milligrams is what you will be administering. So that's the reason, what are the only two important parameters on which loading dose is dependent, doctor? Number one, the volume of distribution, and number two, the peak concentration, which is considered to be the therapeutic concentration for you to achieve the therapeutic level, is what I want to underscore to all of you. So that's the reason, what is going to be your answer, doctor? It is the loading dose depends on the drug concentration to be achieved, and also upon the volume of the distribution, and also the bioavailability, obviously. Where is this concentration achieved, doctor? In the plasma. So there's a reason even bioavailability will decide the loading dose, but not the clearance, which will, maintenance doses depend on the clearance. Now you have to be doubly sure about. So let's go to the